Hello students, now let's talk about the pharmacology of individual drugs which is used in the treatment of SARS-CoV-2 infections. We all know the basic nature of SARS-CoV-2. This is a single-stranded RNA which is enveloped, it's a positive sense and it belongs to beta coronaviridae. Overall, the drugs which can be used in the treatment of this can be classified into two major types. All of these drugs which is currently being used is going to inhibit a particular protein in this SARS-CoV-2. But how are we going to classify those? It's going to be classified into two major groups of drugs. The first group which is going to inhibit the structural proteins of SARS-CoV-2 and the second one which is inhibiting the non-structural proteins of SARS-CoV-2. So consider we have this SARS-CoV-2, we have the spike proteins, the classical feature of this. We also have lipid bilayer along with other proteins which is there on the surface, and inside we all know it is an RNA virus. These drugs can be classified into two major areas: drugs which is inhibiting the structural proteins and drugs which is inhibiting the non-structural proteins. Structural proteins includes only one major area, that is spike protein. And in a space, non-structural proteins, we have four major targets. The first one is 3-chymotrypsin-like protease, papain-like protease, helicase, and the most important enzyme, that is RNA-dependent RNA polymerase enzyme, RDRP. Now regarding the drugs which is going to inhibit individual proteins, first let's talk about drugs inhibiting the structural protein, that is spike proteins. Two drugs are there, one is your Griffithsin and the next one is Umifenovir. Drugs inhibiting spike protein, we have Griffithsin and Umifenovir. Both of these drugs tends to inhibit the spike proteins. What about 3-chymotrypsin-like protease? This 3-CT-like protease was actually thought that lopinavir and entecavir combination can inhibit this 3-CT-like protease, chymotrypsin-like protease. But later on it was found that this lopinavir and ritonavir, this drug, we all know it is a protease inhibitor, HIV protease inhibitor. So based on the structure, we thought that it might inhibit these two, but it was not so. This drug was found to be very much least effective in inhibition of 3-CT-like protease because of structural differences between HIV protease and 3-CT-like protease. Later on, it was found that this drug is going to be least useful in this treatment. Drugs inhibiting papain-like protease, we have disulfiram. Disulfiram has been found to have an additional inhibition of papain-like protease, but is not being used because of ADR. The risk versus benefit is going to be more oriented towards the risk if we use disulfiram for the treatment. Helicase can be inhibited by triazoles and bananins. And the last and the most important one is your RNA-dependent RNA polymerase, RDRP enzyme. This is what the current target is. The famous drug Remdesivir, Favivir, and the recent analog of Remdesivir, that is Galidesivir. All these drugs tends to inhibit RNA-dependent RNA polymerase enzyme. Clear, mate? So these are the different drugs which we have currently in treatment process for SARS-CoV-2. We also have the other drugs like azithromycin, we have tocilizumab, Merimpodib, many newer drugs are there, but the basic one with which the mechanism of action has been clearly established, which is targeting the particular viruses, we have listed it above. Now let's talk about the first drug which was actually thought to be the drug of choice, the first drug of choice in treatment of SARS-CoV-2 infection. Yeah, many of you would have guessed it, guys, chloroquine or hydroxychloroquine. It was being taken out from this treatment process because of adverse drug reactions and also least efficacy as compared to the newer drugs. But anyhow, we have a need to know the important areas for CQ and HCQ. That's what we're talking about right now. We're going to talk about chloroquine or hydroxychloroquine. This drug has got how it is going to target the SARS-CoV-2 infections. It is going to be targeting via three major mechanisms. Three major mechanisms are there. The first one, it tends to increase the entry of zinc into the virus infected cells. Increases zinc entry into virus infected cells. First mechanism. The second mechanism, it tends to block terminal glycosylation. It tends to block terminal glycosylation. So what is the procedure behind it? So by blocking the terminal glycosylation, it prevents the binding of, prevents ACE receptor binding with SARS-CoV-2. Prevents AC receptor binding with SARS-CoV-2, the second mechanism. And the third mechanism is chloroquine and hydroxychloroquine. Many of you would have guessed it. The drug's name is ending with INE, which means this drug is a acidic drug or basic drug, guys. Exactly, this drug is a basic drug. So this drug are actually weak bases. So when it is administered, it gets concentrated in the acidic vesicles, and there it is going to inhibit this heme polymerase enzyme. It just prevents the polymerization of heme. It gets concentrated on the acidic vesicles. So thereby it is going to inhibit polymerization of heme. Three major mechanisms, guys, for CQ or chloroquine or hydroxychloroquine. Among these, which drugs was found to be more effective? Hydroxychloroquine was found to be more effective. Now we are going to talk about the pharmacokinetic features of these drugs. This drug has got three major metabolites, especially hydroxychloroquine has got three major metabolites. The first one is des-ethyl hydroxychloroquine. Similarly, we have des-ethyl chloroquine, and we have bi-des-ethyl hydroxychloroquine. Among this, the first one, des-ethyl hydroxychloroquine, is the major metabolite of HCQ. The major issue with this pharmacokinetic features, the classical feature of HCQ is it has got two different ranges of half-lives, right? We are talking about the absorption T-half and the terminal T-half. Absorption T-half and terminal T-half. Absorption T-half is going to be lasting for around 3 to 4 hours, whereas terminal T-half is going to last for a longer duration of time. It is going to be lasting for around 40 to 50 days. Why is this happening? Is because this drug has got a high volume of distribution. As it has got a high volume of distribution, it has got very least propensity to be excreted out from the body. So the duration of action, to say the terminal T-half, is going to be longer for hydroxychloroquine, especially hydroxychloroquine we are talking. Now all these drugs is going to be excreted out via which route? Feces or urine? It is going to be excreted out via urine. Clear? Now coming towards the most important area, the adverse effects and the drug interactions. These two are the primary reasons why this drug is currently not being recommended. We are going to talk about adverse drug reactions. It produces a list of areas starting from top till bottom. We can simply say it's going to affect your brain, it affects your eyes, your heart, liver, kidney, your muscle, blood and skin. All these areas is going to get affected if your patient is treated with hydroxychloroquine. Simply, first start from the topmost area. It's going to affect your brain. In brain, it might produce simply, this is one more thing to remember, guys. So in brain, it is going to be increasing your suicidality. Suicidal tendencies is going to be more if a patient is on a long-term treatment with hydroxychloroquine. The next one, next comes your eyes. In eyes, there might be development of irreversible retinal damage. Irreversible retinal damage might be there, which warrants that we need to monitor the patient annually if a patient is on long-term therapy. For SARS-CoV-2, we are not going to treat the patient for long-term. Once a short-term therapy is enough, but in case of many different conditions, including your rheumatoid, we can use hydroxychloroquine for a longer period of time. In those conditions, we have to monitor. Annual monitoring has to be done. Best corrected visual acuity has to be monitored. We have to monitor your central 24-degree visual field and also your spectral domain OCT, optical coherence tomography. All these things has to be monitored annually, and the most important one is this annual monitoring of retinal damage has to be done annually if a patient is on long-term treatment, if a patient is on continuous therapy, if a patient starts developing symptoms. This is a particular indication of discontinuing the treatment, guys. If in case a patient develops irreversible retinal damage, it is a thing for discontinuing the treatment. Why? Because the retinal damage is going to be irreversible in nature. Clear, mate? Now the third area is your cardiac muscles, your heart. In heart, we can expect an AV block. Some patients might develop a pulmonary hypertension, sick sinus syndrome. Certain patients might also develop QT prolongation. These are the different cardiac anomalies, that is adverse effects which we can expect if a patient is on treatment with hydroxychloroquine. And if in case any patient develops these kind of adverse drug reactions, again this warrants the discontinuation of therapy. This also warrants a discontinuation of therapy. Now coming towards the next one. So we have finished brain, eyes, heart, and we have liver and kidney. In case of hepatic failure and in case of renal failure, there must be caution needs to be advised if a patient is on treatment with HCQ. Hepatic failure or renal failure, caution needs to be advised if a patient is on treatment, has to be treated with hydroxychloroquine. And the next one, we have blood, muscle and kidney. In blood, this is what the most important one is. In blood, it might produce hypoglycemia and it might also produce life-threatening hypoglycemia. So we need to have a clear-cut monitoring of the blood sugar if a patient is on long-term therapy with HCQ. So there might be development of life-threatening hypoglycemia. Also, some patients might develop aplastic anemia or a granulocytosis. Again, this also warrants discontinuation of therapy. For all the other conditions, there is no necessity for discontinuation of therapy, except for all these areas which we are explaining about right now. Blood, muscle and skin. Muscles. In muscles, it might produce proximal myopathy and also neuropathy. And the last one is about in skins. In skin, it might aggravate psoriasis. And some patients might also be developing porphyria. These are the different adverse effects which we can expect with hydroxychloroquine. Starting from top till the bottom, we have affected it. It affects your brain, eyes, heart, liver, kidney, blood, muscle and skin. In all these areas, there is going to be adverse drug reactions, and that's what we are explaining about right now. Clear? Now let's talk about the next one regarding hydroxychloroquine. We are talking about drug interactions of hydroxychloroquine. Drug interactions of hydroxychloroquine. If hydroxychloroquine is given with mefloquine, you know what is mefloquine is, right? It's also an anti-malarial agent. If hydroxychloroquine is added with mefloquine, mefloquine also has a tendency to produce neurotoxicity or neuropsychiatric disturbances. There might also be development of epilepsy if a patient is on treatment with mefloquine. If hydroxychloroquine is added with mefloquine, there is more chances of epilepsy. So this combination behaves as an epileptogenic agent. And hydroxychloroquine also increases the effects of four major drugs: digoxin, insulin, cyclosporin, and the other QT prolonging agents. Any drugs which is going to prolong the QT interval, if it is given with hydroxychloroquine, there is more chances of it. Similarly, digoxin, insulin and cyclosporin, these adverse effects which we can expect with these three drugs tends to be increased if a patient is on treatment with hydroxychloroquine. Clear? Now, the opposite effect, hydroxychloroquine can also decrease the effects of three major drugs. The first one is anti-epileptic agents, because it might induce the production of epilepsy: praziquantel, the anti-helminthic agent, and the famous and most common drug which we use, ampicillin. All these drugs' effect is going to be decreased if it is combined with hydroxychloroquine, guys. Is that clear? Now recently it has been found that this chloroquine has got one additional mechanism. Chloroquine also has got blockade of topoisomerase enzyme. Also blocks topoisomerase 2. Because of this topoisomerase 2 blockade, chloroquine and also hydroxychloroquine has been ascertained to have a genotoxic effect. With chloroquine, it has been recently found. Also, it has been approved. Also, it has been there for hydroxychloroquine. These are the reasons why these drugs are contraindicated in pregnancy, in infants, and also in children. Contraindicated in pregnancy, in nursing women, and also in children. These drugs are contraindicated because of these different conditions. Is that clear, guys? These are the salient features of chloroquine and hydroxychloroquine. Please remember, as per your HCQ is concerned, the mechanism of action is of least important because currently it is not being prescribed. The reason why this drug was taken out from the regimen is, first thing, efficacy was lesser as compared to the newer drugs. The second one, regarding these different complexes, the adverse effects, the long-term adverse effects, and the drug interactions which we observe. These are the primary reasons why hydroxychloroquine was removed from the market. Not exactly removed from the market. It was removed as a treatment of choice for SARS-CoV-2. So please be noted about this ADR and drug interaction complexes. Now, let's talk about the next drug, that is azithromycin. Currently, it is being used as a prophylactic therapy actually. Azithromycin, this drug being a macrolide antibiotic, this is azithromycin, right? So, if a drug is ending with the term mycin, it might be of many different complexes. How to identify whether it is a macrolide? If the drug name contains romycin, it belongs to a macrolide complex. So, this drug is a macrolide drug, macrolide antibiotic agent. Macrolide antibiotic, it also has got additional antiviral properties too. Antiviral properties. These antiviral properties are especially targeting many different viruses, guys, not only for SARS-CoV-2. We can imply this azithromycin for, it has been studied, it has been told that for Ebola, for Zika virus, for respiratory syncytial viruses, for H1N1 we have tried azithro, for enterovirus and for rhinovirus. For all these different viruses, azithro has been tried out. Even though it has got this antiviral property, it has not been that much as compared to your regular drugs, regular antiviral drugs which we use. That's why we couldn't include this drug under the classification of antiviral agents. Clear, mate? Now, what are the different mechanisms? How it is going to produce this particular mechanism? Not only the antiviral properties, it also has got additional immune modulatory properties. And what are the different properties? It tends to increase the type 1 and 3 interferons. It tends to increase type 1 and 3 interferons. It also activates viral recognition genes. It also activates viral recognition genes. By activating that, it tends to promote the fight of the human body with the viruses. What are the different viral recognition genes? It might be of MDA5 and RIG1. These are the primary mechanisms. It has recently been told that this drug also tends to block viral entry. It is also has been explained as this drug might also block the viral entry, but this mechanism is still not been cleared. It has been one of there in the hypothesis itself. Now, what type of ADR do we expect? What type of adverse drug reactions can be expected? Macrolide, we all know macrolide, OLID is the mnemonic number. In macrolide, we have this OLID as a name. O stands for ototoxicity. LI stands for liver toxicity, or simply there might be development of jaundice or cholestatic jaundice, and D stands for diarrhea. The classical feature here is the ototoxicity due to azithromycin is reversible in nature as compared to your aminoglycosides. Aminoglycosides, it tends to produce irreversible ototoxicity, whereas macrolides tend to produce reversible ototoxicity. Liver, that's what we have explained it right now. It might produce cholestatic jaundice. It might produce cholestatic jaundice. And diarrhea, why is it? Because macrolides tend to act as an agonistic agent at motilin receptors. Motilin receptor agonistic agent. This drug also might act as an motilin receptor agonistic agent, and that's why this drug also tends to produce diarrhea. And most importantly, macrolides are microsomal enzyme inhibitor agents. Lots of drug interactions can be expected, but not with azithromycin, guys, because azithromycin tends to have least effect on the microsomal enzymes. So it is comparatively safer to the other macrolides like erythromycin or roxithromycin or clarithromycin. Compared to majorly the classical example of a microsomal enzyme inhibitor among the macrolides is erythromycin. As compared to erythromycin, azithromycin is compared to be a safer and a better alternative, guys. Clear? Now we'll move on to the next and the most important drug currently being used in the treatment of SARS-CoV-2, Remdesivir. Remdesivir is the drug which can be given via parenteral route. Recently it has shown promise in the treatment of SARS-CoV-2 patients. Many patients has been revoked back with Remdesivir infections. For what all different other viruses we can use Remdesivir, but like how azithromycin has been tried for many different viruses, Remdesivir has been tried for similar with Ebola, for Marburg viruses, for Nipah, and also for SARS-CoV-2. For four of these viruses, we have tried Remdesivir as a treatment of choice, as one of the treatment options. This drug is actually a prodrug of C. adenosine. This drug actually is a phosphoramidate adenosine nucleotide. Phosphoramidate adenosine nucleotide. This drug belongs to a nucleotide complexes. That is why this drug is structurally very similar to tenofovir. We all know tenofovir alafenamide, right? This drug is structurally similar to tenofovir alafenamide. Tenofovir alafenamide. We all know that tenofovir is actually a nucleotide analog, nucleotide reverse transcriptase inhibitor, whereas the other drugs like your zidovudin or lamivudin tends to be a nucleoside reverse transcriptase inhibitor. Both of these drugs can be used, like your zidovudin, lamivudin, and also tenofovir are actually used under treatment for HIV infections. Like under heart regimen, we are using tenofovir as the first line therapy. So this drug Remdesivir is structurally very similar to tenofovir. So we can simply say this is also a nucleotide analog agent. Now how this drug is going to produce the action, guys? A similar complex like how tenofovir is going to act on. Consider we have this virus. So this is your virus we have. Now inside the viruses, normally we have the nucleic acid molecule, and this nucleic acid molecule is going to be getting polymerized. So what happens? It is going to be polymerized with the help of an enzyme that is RNA dependent RNA polymerase enzyme, RNA dependent RNA polymerase. Now this patient has been treated with our famous drug that is Remdesivir, RMD. Remdesivir tends to gain entry into the virus. Now inside the virus it gets converted to an active form. It is not converted to an active form outside the viruses. Only when it gains entry into the virus, it is going to be converted to get active forms. And once it gets converted to the active form, it gets incorporated in this process. It gets incorporated in this nucleic acid process because it's a nucleotide analog. Instead of a normal human being nucleotide, which the virus normally utilizes, it is going to incorporate this abnormal Remdesivir nucleotide. By incorporating that, it means what? The RNA dependent RNA polymerase finds out that we have a mistake in the polymerization reactions to occur. So what happens? Everything comes to a halt. Clear? So this is going to cause further inhibition of this RNA dependent RNA polymerase. Right? This is going to cause further inhibition of RNA dependent RNA polymerase because this is the rate limiting enzyme. It is going to be following it up as early as possible. Only if the correct level of correct amount of this nucleotide is going to be synthesized, it is going to be working further. If it is not so, it is not going to work further, guys. Clear? But do you think that a normal replication of a virus, there is not going to be any type of mixtase in it? No, there is going to be a mistake in it. There might be a mistake in it during a normal replication of the virus, but don't worry, the viruses has got a backup mechanism, right? Normally, this is found out. Normally, these are corrected by exoribonuclease. We used to call it as exons. Normally, this is going to be corrected by exoribonucleases, but Remdesivir couldn't be corrected out by exons. That is the classical feature of this Remdesivir. Clear, mates? Because it is going to be forming a stronger bond with its structure, and there is going to be lots of DNA strand abnormalities, RNA strand abnormalities is going to be there, and because of it, the exon fails to identify this Remdesivir nucleotide. And that's the reason why RDRP is going to be halted. Why am I talking about this exon complexes is because we have also seen about one important drug, that is Ribavaran. Ribavaran also has got a somewhat similar mechanism, but this Ribavaran can be easily found out by this exon. Clear? Even though Ribavaran was found to be an extensive drug which can be used in the treatment of herpes or hepatitis, any other functions, but here we can't utilize it. Why? Because it can be easily found out by this SARS-CoV-2's exon, and it can be easily removed out from this nucleic acid complexes. That's the reason why Ribavaran was found to be less effective in vitro. Clear, mate? Now, let's talk about certain salient features of these drugs, that is your pharmacokinetic features. Pharmacokinetic features, the first one, what's the plasma T-half? The plasma T-half of this drug is around 1 hour. We're going to find out the reasons behind every individual complexes. And why is it 1 hour? Why is it 1 hour? Is because Remdesivir is rapidly dehydrated by plasma enzymes. Rapidly metabolized by plasma hydroxylase enzyme. So plasma hydroxylase enzyme is going to be rapidly degrading it, and that's the reason why the patient's plasma T-half of Remdesivir is going to be very much shorter. But the plasma T-half of the metabolite, active metabolite, is a little bit longer. Lasts for around 24 hours. And this active metabolite is going to be excreted out in the urine. Is going to be excreted out in the urine. So we can expect a change. We can expect a renal abnormality in the adverse drug reactions. Clear? We can also expect that the dose of this drug needs to be decreased if a patient has got deficit renal functions. If the creatinine clearance or if the GFR is going to be altered in a patient, we have to decrease the dose, or we can be contraindicated. We'll be talking about that later on. We all know that this drug belongs to a phosphoramidate, right? Phosphoramidate adenosine metabolite. Phosphoramidate adenosine nucleotide drug. As it is a phosphoramidate, phosphoramidates usually has got a high first pass metabolism. If it is taken via peroral route, there is going to be very high first pass metabolism. Very least drug is going to gain entry into your blood, and that's the reason why Remdesivir is given via parenteral route, guys. High first pass metabolism. This is the reason why this drug is given via parenteral route. And the next point, this drug tends to be a faster acting agent. Faster acting, the onset of action is a little bit quicker as compared to the other drug. And why is it so? And why is it so? Is because we have the normal nucleotide, the normal human nucleotide, which is going to get incorporated on the nucleic acid area of the virus. The normal nucleotide must first be converted to a monophosphate, and from that it needs to be converted to a triphosphate. After conversion to the triphosphate, it is going to get incorporated. The conversion of a normal human nucleotide to a monophosphate remains the rate limiting step, which means it's going to be the slowest step to occur. Whereas Remdesivir itself is a bioisoter of a monophosphate mechanism. This itself is a monophosphate. So it just bypasses this rate limiting step. It needs to be just converted to the triphosphate, which is happening inside the viruses. That's what we have explained previously. So Remdesivir itself is a monophosphate. It bypasses the rate limiting step. It gets converted to triphosphate directly, and that's the reason why this drug is a faster acting agent. We have the natural nucleotide. It gets converted to a monophosphate mechanism. This monophosphate conversion, as I've already explained, is the rate limiting step. And post conversion from monophosphate to triphosphate is going to be incorporated, it's going to be utilized by the virus. That is not going to be seen with Remdesivir. Why? Because guys, Remdesivir itself is a bioisoter of monophosphate. Remdesivir itself is a bioisoter of monophosphate. It needs to be converted to triphosphate. That's it. There is no major mechanisms to be involved in it. It bypasses this rate limiting step. Bypasses the rate limiting step, and that's the reason why this drug is going to be faster acting one. We are also going to find out an important other application of this conversion point. The conversion of RMD to a triphosphate mechanism is inhibited by a famous drug, guys. Anyone can guess? This conversion, to say this activation of Remdesivir to triphosphate is inhibited by a famous drug which was actually used for the treatment of SARS-CoV-2, exactly chloroquine or hydroxychloroquine. This step is going to be inhibited by chloroquine or hydroxychloroquine. And this is the reason why Remdesivir is not given with chloroquine or hydroxychloroquine, because Remdesivir is not going to be converted to the active form. It is going to be remain as an inactive one. There is not going to be any use in administration of this drug. Clear, guys? Now the next one, when this drug is administered as a rapid IV. As we already explained, this drug can be given via parenteral route. Why? Because it has got high first pass metabolism. So when it is given via parenteral route IV, if it is given as rapid IV, the patient might develop hypotension. Some patients might develop cardiac arrest and death. What is the application of knowing that? This is the reason why this drug is given as an infusion over a period of around 60 minutes, over a period of around 60 minutes. These are the different pharmacokinetic features and its applications for Remdesivir, guys. Now let's talk about the adverse drug effects. Many of us, has been covered up previously. So what are the major areas which we can expect? Common one, we have nausea, vomiting. Some patients might develop constipation or headache. Most important one, recently it has been found that this drug is associated with anemia and lymphopenia. Anemia and lymphopenia can be associated with that. Some patients might develop hyperglycemia. Some patients might develop hyperglycemia. Because this drug is given via infusion, there might be development of infusion related reactions. Infusion related reactions, and coming towards the most important one, whether can it be given in case of renal failure or not, guys? Yeah, we have already discussed it, right? We know the mechanism behind it. In renal failure, this drug is going to be given, but with caution. How are we going to be cautious? We are going to monitor the eGFR. In renal failure, this drug is going to be contraindicated if the eGFR is less than 30 ml per minute. This drug is going to be contraindicated if eGFR is less than 30 ml per minute, and this drug is contraindicated with vasopressor agents. Vasopressor agents, because it might produce an end organ damage. It might produce end organ failure, and because of it, this drug is going to be contraindicated with the vasopressors. Clear? Now, what type of resistance can be developed? Is there any possibility? I hope SARS-CoV-2 doesn't hear what we are saying, what we are discussing here. It's because we have seen resistance developed against Remdesivir for other viruses. When we have used Remdesivir for other viruses like your Nipah virus or Marburg or Ebola viruses, we have seen a mutation in the RDRP. This RNA-dependent RNA polymerase has got mutated and structure has got changed. So if the structure has got changed, this drug is not going to be effective. That's what we can expect. But till now, resistance is going to be very much lesser. It has been not seen as per till now, but values are always going to be different. So till now, the resistance is not been very much widespread, but we can expect a mutation which might happen with RDRP, RNA-dependent RNA polymerase, guys. These are the salient features of the famous drug Remdesivir, which we are currently administering for the treatment of SARS-CoV-2, and it has shown some positive responses too. Now let's talk about one more drug which has been recently been seen in India. It has been just before a few months. It has been told like this drug can be given as combination. It has come to the market in India. Many different controversies were going on. Yeah, we are talking about Favipiravir. Favipiravir is a drug which can be given via peroral route, guys. It can be given via peroral route. The first one, this drug is a broad spectrum antiviral agent. Not an antiviral agent, it's an anti-RNA viral agent. Broad spectrum anti-RNA viral agent. Which means, what is the application of knowing that? It has got no effect on DNA viruses. It has got no effect on the DNA viruses. First classical feature. The next one, it tends to block the replication of what are the other viruses. Again, it is going to be effective for. Favipiravir is going to be effective for what are the other viruses? Influenza. The common influenza A, influenza B, avian influenza, Ebola, Lassa virus, and also Covid19 or SARS-CoV-2. For SARS-CoV-2. Influenza A and B, even if the virus is resistant to neuraminidase inhibitors, we can give these drugs. This is going to be the next treatment of choice. So even if the virus is going to be neuraminidase inhibitor resistant, it might be Favipiravir can be utilized for this treatment of these conditions. Clear? Now what about the mechanism? A similar one, guys, no major change in it. So this drug is actually a prodrug. Prodrug Favipiravir is converted to the active form FRTR. This is done with the help of intracellular phosphoribosylation. With the aid of intracellular phosphoribosylation, prodrug is going to be converted, and this is going to be recognized as a purine nucleotide by the virus. Similar mechanism as ditto to what we have seen in Remdesivir. So it's going to behave as an nucleotide. It behaves as a purine nucleotide. It is going to be binding off. Thereby, it is going to inhibit RDRB. It is recognized as a purine nucleotide. It is recognized as purine nucleotide. It is going to be competing with the purine, so thereby it is going to inhibit RNA dependent RNA polymerase. Clear, mate? This is the mechanism. The mechanism which we have seen for Remdesivir, a similar one, but we have a take-home message for this. This active form of this drug, this is the purine nucleotide form of this Favipiravir, how it is going to get inactivated, how it is going to be removed out from the body. This is going to get removed out by hydroxylation by two different enzymes. Hydroxylation, the removal of Favipiravir is dependent on two major enzymes. The first one is aldehyde oxidase. And the next one is xanthine oxidase. Both of these enzymes are involved. Yeah, you have guessed it right. Majority would have seen, oh, xanthine oxidase, yeah, the same enzyme. So xanthine oxidase is an enzyme is going to be involved in the hydroxylation of Favipiravir. That is the reason why this drug is contraindicated in, yeah, I can hear you screaming out the answer like this drug is contraindicated in gout. And also because of these different metabolisms, it gets excreted out in the urine, guys. It gets excreted out in the urines. Now, what are the different adverse effects which we can expect? Usual ones, no major ones, but the most important one which you should need to be remembering is this drug is powerful teratogenic agent. Favipiravir is a teratogenic agent. It might cause bone marrow depression, like how we have seen with the Remdesivir. It might produce anemia and lymphopenia, also can be seen with Favipiravir. There might be development of hepatotoxicity, raised liver enzymes can be expected, and diarrhea can be seen with Favipiravir. These are the most common ADAs, adverse effects of Favipiravir. Clear, guys? So please remember Remdesivir, Favipravir, Chloroquine, Hydroxychloroquine, all of these 4 drugs are very much important one. Now we'll be talking about the next drug, Ribavaran. I hope we have already explained one important point about Ribavaran, guys. Remember that? Yeah. Ribavaran can be easily found out by the exoribonuclease, exon molecules. So this drug is going to be very much least effective in vitro. It was, as per the mechanism is concerned, it is going to be the perfect drug in treatment of SARS-CoV-2. But in vitro, because of this exon, this drug is going to be of least effective use. How it is going to produce this effect? Ribavaran tends to be converted to monophosphate. It tends to be converted to again triphosphate. This conversion to monophosphate also is going to be occurring where? Inside the cells or outside the cells? Intracellular. Intracellular phosphorybosylation will happen. So RMP and also RTP is going to be there, and this RTP is going to be involved in the inhibition of a particular enzyme. And what's that enzyme, guys? The enzyme which is going to be aided in the conversion of inosine phosphate, 5-phosphate, to be converted to xanthosine 5-phosphate. And this conversion is aided by the famous enzyme, and that is inosine monophosphate dehydrogenase enzyme. That is going to be inhibited by this RTP Ribavaran molecule. This IMPDH is the rate limiting enzyme in the de novo synthesis of purines. So this enzyme is going to be inhibited by this RTP, and because of it there is going to be decreased intracellular GTP. And because of it there is going to be decreased intracellular GTP molecules. So thereby there is going to be inhibition in RNA replication. There is going to be inhibition in RNA replication. This is where we have explained it previously, guys. This RTP molecule can be easily found out by the exon molecules, and because of it, it was found to be least effective in vitro, but later on it was found to be a little bit effective. It is not going to be completely inactive in treatment of SARS-CoV-2. So we are still using Ribavaran for the treatment of SARS-CoV-2. Is that clear, mate? What are the different adverse effects? The major ADR which can be expected is when this Ribavaran is given at high doses, severe anemia might be resulted out. Severe anemia is seen at high doses, and this drug has got a major drug interaction with warfarin. Major drug interaction with warfarin. This drug should not be administered with warfarin. Clear, mate? That's it about your Ribavaran. Now we'll move to the next drug, Umifenovir. Umifenovir is a true broad spectrum antiviral agent, not unlike Favipravir, which is purely a broad spectrum anti-RNA viral agent. This drug is purely a broad spectrum antiviral agent, which means it is going to be covering up DNA and RNA, capsulated or non-capsulated. Any different viruses, this drug is going to be affecting out. Like how we have broad spectrum antibacterial drugs, we have a broad spectrum antiviral. Broad spectrum virucidal agent. It's going to be covering up both enveloped or non-enveloped DNA or RNA viruses. RNA viruses. How are we using it? This is tried with Favipravir. This is tried with Favipravir. The major mechanism of how this drug is going to get excreted out is unchanged via urine. Unchanged in the urine, and that's also one of the reasons why this drug has got a long elimination T-half. Around 25 hours is the elimination T-half of Umifenovir. 25 hours is the elimination T-half of Umifenovir. Clear? How this drug is going to be acting as a broad spectrum virucidal agent, again, like how we have seen about hydroxychloroquine, this drug also has got 3 mechanisms of action. Mechanism of action, there are 3 major mechanisms. The first one, DAA, HTA, IFN. What is DAA, guys? Directly acting antiviral agent. It has got directly acting antiviral property, and how it is going to produce? It acts as a heme agglutinin inhibitor. This drug acts as a hemagglutinin inhibitor, and because of it, it also has got additional mechanisms of how it can be classified as a directly acting antiviral agent. It's going to inhibit clathrin mediated exocytosis, and also it inhibits viral entry. Because of these three different mechanisms, we have been explained that imipenemivir can act as a directly acting antiviral agent. What about HTA, guys? HTA means host targeting agent. It just doesn't target the virus, it also targets the host cells. It tends to increase the preparedness of the host cell against the infection with this virus. Host targeting agent, HTA. How it is going to be inhibiting? By inhibiting viral proteins and lipids. Interferons, it tends to increase the level of interferons. It tends to increase the level of interferon, so thereby it tends to increase phagocytosis of cells. It tends to increase phagocytosis functions of your macrophages. Clear? These are the three major mechanisms by which this drug can be used as a broad spectrum antiviral agent, especially we are targeting your SARS-CoV-2 infections. Now, moving towards the next drug, this drug tends to be not given as a monotherapy agent. It can be tried as an add-on therapy, and that drug is Merimpodib. Merimpodib is given via peroral route. This drug actually is an anti-hepatitis C drug. This drug also has got a similar mechanism of how we have seen with Ribavaran. This drug also is a non-competitive, irreversible inhibitor of inosine monophosphate dehydrogenase enzyme, and because of it there is going to be decreased intracellular GTP molecules, and because of it there is going to be blockade of RNA and DNA synthesis and blockade of viral replication. As it is blocking RNA synthesis and DNA synthesis and viral replication, Merimpodib also can be classified as a DAA drug. What's the DAA, guys? Directly acting antiviral agent. This is also a directly acting antiviral agent. But the issue here is we can easily reverse this action back. We can reverse the action of Merimpodib by administration of exogenous guanine, simple. By administration of exogenous guanine, we can easily reverse this action of Merimpodib, and that's why it has not been used commonly as monotherapy. It can be used especially as an add-on therapy with the regular regimens which we have. So it is acting as a directly acting antiviral agent. It also has an immunosuppressive property. By blocking this IMPDH, it also tends to block lymphocyte proliferation. So not only in the virus, even in lymphocyte, this IMPDH is going to be blocked. So lymphocyte proliferation also is going to be inhibited. So thereby it tends to have immunosuppressive property. Immunosuppressive property. Clear? Now, as it is decreasing this GTP molecule, as it is decreasing the GTP molecules, it also tends to increase rate of incorporation of Ribavaran. And that's the reason why Merimpodib can be given as an augmenting agent. It augments the action of Ribavaran and Favivir. It augments the action of Ribavaran and Favivir. Merimpodib has got this action, and that's why we have explained that this drug can be better given as an add-on therapy with Ribavaran or with Favivir for increasing its action. To say it tends to augment the action, it tends to have additional action of what Ribavaran and Favivir is actually going to do. Merimpodib can produce least adverse drug reactions as compared to your Ribavaran or Favivir. That also poses a safety advantage over other drugs. It has got least adverse effect, like it might produce fatigue, nausea or vomiting or diarrhea. No major adverse effect has been found out till now. So Merimpodib is comparatively a safer alternative as an add-on therapy, or in some cases if it is found to be effective, we can try it as a monotherapy too. Similarly, we have one more drug, a recent drug which has been included, which has been studied extensively, and that is Rintamimod. Rintamimod, the drug given via parenteral route, intravenous route. This drug is actually a synthetic double-stranded RNA molecule. Synthetic double-stranded RNA molecule. This drug tends to act as an agonist at toll-like receptor 3. What is this toll-like receptor, guys? We know that it's nothing but a natural signal which is defending a viral infections. Natural signal defending a viral infections, toll-like 3, and that is going to be agonized by the Rintamimod. So thereby it is going to be preventing the further progression of the particular disease. But it has got an important point. This Rintamimod, this does not increase the level of interferon alpha. It does not increase interferon levels. It just prevents the further progression of the disease. Simply the cytokine storm and the immune system complexes is going to be weakened off, and there is going to be increase in the antiviral property of the human body. These are the different drugs which we have currently. Also, we have a monoclonal antibody, and that is tocilizumab. Tocilizumab is an anti-interleukin 6 antibody. We have vitamin C and vitamin D. This tends to block inflammatory response. This tends to block inflammatory response, especially because of a RAS system. Inflammatory response, if it is because of RAS, that is going to be inhibited. Also, vitamin D and C has got certain additional mechanisms, like it might induce antimicrobial peptides in the body. It might induce antimicrobial peptides in the body, like human cathelicidin. It might induce these antimicrobial peptides, and that's how this drug also can be used, can be tried in the treatment of SARS-CoV-2. Vitamin C, lots of studies has been done, but vitamin D, even though the theory explains a stronger association in treatment of SARS-CoV-2, many studies fail to produce certain response, but we need a larger amount of study for explaining that vitamin D also has gotten certain effect on SARS-CoV-2 infections. Clear, mate? So this is an overview of drugs which can be used in treatment of SARS-CoV-2. We are concentrating especially on the pharmacological properties of individual drugs, guys. Many drugs are being added. I am just it has been a difficult work to concise all those drugs to most commonly used ones. I hope it will be of particular use to you. Now I'll be talking about certain multiple choice questions related to SARS-CoV-2 pharmacology. The first question which we are going to talk about today is, which of the following statements regarding management of hydroxychloroquine poisoning is false? Recently, it has been told like hydroxychloroquine was actually thought to be the first drug of choice previously, but it has been taken out from the treatment regimen because of adverse drug reactions. The issue with hydroxychloroquine is majority of the patients forget about the doses and they used to get into poisoning stages. So we have to know which will be the treatment for hydroxychloroquine poisoning. And the question was, which is false, right? Which of the statement is false? So, as per HCQ poisoning is concerned, hydroxychloroquine poisoning is concerned, the first thing, we have to opt for a gastric lavage. We can use activated charcoal. We can use diazepam and ammonium chloride. We don't have a specific drug of choice for the treatment of HCQ poisoning. It is purely based on symptomatic management. Ammonium chloride. What are the different uses of it? How are we going to proceed with that? Activated charcoal we can use for HCQ poisoning, and the dose which we prescribe is going to be 5 times the dose of hydroxychloroquine which the patient has taken up. So that much amount of activated charcoal is necessary for preventing the absorption of HCQ. Diazepam can be used. Why do we use diazepam? Because we know that the most important ADR of hydroxychloroquine is it might produce irreversible retinal damage and it might produce cardiotoxicity. In order to prevent that cardiotoxicity, diazepam tends to play a role. Diazepam tends to prevent development of cardiotoxicity. And hydroxychloroquine, which why do we administer ammonium chloride here? It's because, guys, we all know that if a drug's name is going to end with INE, right? If a drug's name is going to end with INE, it is a basic drug most probably, right? Why is it? Because again we have one more point, like if a drug is fused with an anion like sulfate or bromide or iodide or chloride, these are negative charged molecules. If any drug is going to be forming a salt with a negative charged molecule with an anion, that is going to be a basic drug. We all know, again rewinding back to the general pharmacology, in order to excrete out a basic drug, we have to acidify the urine. In order to excrete out an acidic drug, we have to alkalinize the urine. Hydroxychloroquine, it is ending with INE, and this drug is purely a basic drug. We also tend to call it as chloroquine sulfate at some times, because it's also binding with an anion, which is also a second confirmation that this is a basic drug. So ammonium chloride can be used to acidify the urine, so that it can be easily excreted out. These are the different steps in management of hydroxychloroquine poisoning. Now moving on to the options which we have here. Which of the following statements regarding management of hydroxychloroquine poisoning is false? Activated charcoal is used 5 times the dose of hydroxychloroquine. True or false, guys? Yes, it's true. Use of diazepam decreases cardiotoxicity. True statement. Urine is alkalinized with ammonium chloride. False statement. Why is it? Because it is not alkalinized, the urine is acidified with ammonium chloride. Caution is advised in renal failure. Yes, it's true, because the drug might be excreted out in the urine. So in case of renal failure, the drug might accumulate in the body, leading on to toxicity symptoms. Clear, guys? Moving on to the next question. Remdesivir is a bioisoter of monophosphate, diphosphate, triphosphate, none of the above. This is an important question. It appears like a direct question. Mostly this kind of questions is not going to be asked in your exams, but we have to have an important point. That's why we have derived with this question, guys. Remdesivir is actually a bioisoter of a monophosphate. And why is it more important as per application is concerned? As we've already explained in the SARS-CoV-2 pharmacology, I'm just going to repeat it back. We have a natural nucleoside. The natural nucleosides first needs to be converted to monophosphate, and then it is going to be converted to triphosphate. This triphosphate is going to get incorporated, leading on to blockade of the primary enzyme, that is RNA dependent RNA polymerase, right? So as this is a natural nucleotide, RNA dependent RNA polymerase is going to be stimulated and the further process is going to continue, guys. But here, what is the method of treatment by administering remdesivir is, remdesivir tends to inhibit this RNA dependent RNA polymerase. And how it is going to do that? Instead of a natural triphosphate, we have the unnatural, we have the structurally dissimilar remdesivir triphosphate which is there. Because of the change in this base pair, this RDRP tends to get inhibited because of that change. So how this change is going to occur, that's what major concept is. Remdesivir itself is a bioisoter of a monophosphate. So the first step is going to be bypassed, right? The first step of conversion of a natural nucleoside to a monophosphate is going to be bypassed, and this remdesivir is going to be directly converted to a triphosphate, and it is going to get incorporated, leading on to inhibition of RNA dependent RNA polymerase. And why do you think is more important this particular concept is, this natural nucleoside converted to monophosphate is the rate limiting step, behaves as the rate limiting step, and that rate limiting step is going to be bypassed with this remdesivir, and that is the reason why remdesivir is a fast acting agent. It has got a very quick onset of action, although the T-half is also going to be shorter. We'll be talking more about that, but the onset of action is going to be faster because it is going to bypass this rate limiting step. The bypass is going to bypass the slowest step in the activation of the nucleoside complex. So the answer here is remdesivir is a bioisoter of monophosphate, guys. Now moving on to the next question. Which of the following drugs does not act on non-structural proteins? The question is clearly based on what we have already explained in SARS-CoV-2 pharmacology, guys. SARS-CoV-2, what are the different targets which we have as pharmacologically? 2 different targets are there. We might target the structural proteins and functional proteins. We might target the structural proteins and non-structural proteins. Non-structural proteins. Structural proteins, what are these guys? The most important one, I hope many of you would have been knowing it, spike proteins, which is the classical one, and that's how the vaccine has been recently found out. Non-structural proteins, we have 3 chymotrypsin-like protease. The second one, papain-like protease, helicase, and RNA-dependent RNA polymerase. These are the different targets which we have for SARS-CoV-2 regarding the drug treatments as we are talking about. Among this, which of the drugs as per the list is concerned, we are going to talk about individual drugs and what is the target of those individual drugs, guys. So in the options, it has been clearly explained which of the following does not act on the non-structural proteins, which means it's going to act especially on the structural proteins, and that is Imifinovir. Imifinovir has got more orientation towards structural proteins. It has got very minimal activity on non-structural proteins. What about the remaining options? Favipiravir, Remdesivir, both of these drugs tend to inhibit RNA-dependent RNA polymerase enzyme. Lopinavir, previously it was thought that Lopinavir, we all know that Lopinavir is an antiretroviral agent, right? It is a protease inhibitor in your retrovirus. So we thought that it might also inhibit the 3 chymotrypsin-like protease in the SARS-CoV-2. So we started implying that, but later on it was found that it has got least activity in inhibition of this SARS-CoV-2's 3 chymotrypsin-like protease because of loss of structural dissimilarities between this protease and the HIV protease. Later on it was withdrawn as a treatment of choice. But currently we use Remdesivir, which is the primary target is RDRB. We go to the next question. Which of the following statements regarding Remdesivir is true? Plasma T-half of active metabolite is short. Let's talk about individual statements, guys, whether we're going to talk about whether it is true or false. The first statement, plasma T-half of active metabolite is short. Yes, plasma T-half of Remdesivir is short. The plasma T-half of Remdesivir is short. It is going to be just 1 hour, but the plasma T-half of the active metabolite is longer. It lasts for around 24 hours. Both are different, guys. So the statement is clear, like plasma T-half of the active metabolite is short. No, active metabolite is longer. Remdesivir itself alone has got a shorter T-half. So this statement is a false statement. Remdesivir is poorly absorbed from the intestine. We all know that Remdesivir is not given via peroral route, it is given via parenteral route. Why it is not given via peroral route is, even though the Remdesivir has got minimal absorption, we have already seen that in the explanation of SARS-CoV-2, it has got more first pass metabolism, high first pass metabolism is there. Even though even if it is getting absorbed, those absorbed molecules is not going to gain entry into the circulation because it is broken down by the liver when it passes by it. So it has got high first pass metabolism, and that's why this statement also is a false statement. Conversion to triphosphate is interfered by hydroxychloroquine. Yes, this is a true statement. As we've already seen, Remdesivir monophosphate is converted to triphosphate, right? For getting it into the active complex, that step is going to be inhibited by hydroxychloroquine, also by chloroquine. And this was also one of the reasons why we have seen adverse effects, why we have seen drug interactions between Remdesivir and hydroxychloroquine. It is structurally similar to Adifovir. Of course, it's a false statement. What is this true statement then? It is structurally similar to Tenofovir. It is structurally similar to Tenofovir. It is not structurally similar to Adifovir. Clear, buddies? Moving on to the next question. Which of the following anti-SARS-CoV-2 virus drugs is contraindicated in gout? The answer for this question is Favipiravir, guys. Why is it? Because Favipiravir, we know the mechanism, right? It is going to inhibit RNA-dependent RNA polymerase. How it is going to get metabolized and excreted? What's the fate of it? Favipiravir gets hydroxylated by 2 different enzymes, aldehyde oxidase and xanthine oxidase. I can see your eyebrows moving up. Yeah, xanthine oxidase is involved in the breakdown of Favipiravir, and because of this breakdown, it is going to be excreted out in the urine. It's excreted out in the urine. Because of the involvement of xanthine oxidase, this drug is going to be contraindicated in gout. This drug is going to be contraindicated in gout. Recently, it has been shown like dose must be reduced in gout, but overall, we don't usually prescribe Favipiravir currently. Remdesivir is the drug which is currently being used throughout India. So, Favipiravir, even if you are going to planning to administer it, please make sure that you monitor the uric acid levels regularly. Because in case if the patient is known hyperuricemic, there might be issues with the metabolism concepts. Now the next question, hydroxychloroquine when given with which of the following drugs tend to behave as an epileptogenic agent? This is purely a drug interaction question for hydroxychloroquine, guys. Hydroxychloroquine when it is given with which of the following drugs tend to induce development of seizures? Insulin, when it is given with insulin, hydroxychloroquine when it is given with insulin, already an important ADR of hydroxychloroquine. Adverse effect of hydroxychloroquine is what, guys? Yes, most importantly, hypoglycemia, right? Life-threatening hypoglycemia can be expected. If it is given along with insulin, there might be probability of more hypoglycemia, right? Next one, topiramate and ampicillin. The effect of topiramate and ampicillin is going to be decreased when it is given with hydroxychloroquine. Simply, the effect of insulin is going to be increased. Hypoglycemic effect is going to be increased out. Topiramate, the effect of both of these drugs is going to be decreased. That's also reason why it has behaves as an epileptogenic agent. And also, most important one is here, if you want to select one option, we have to go for mefloquine, because when hydroxychloroquine is given with mefloquine, it tends to induce development of seizures, even in patients who are already non-epileptogenic, right? So, in those patients, we all know mefloquine is a drug which can be used in malaria. It is also contraindicated in cerebral malaria because of CNS related adverse effects. Neuropsychiatric disturbances can be expected with mefloquine, and that drug when it is given with hydroxychloroquine tend to induce development of seizures, and that is the important drug interaction over here, guys. Now the next question, which of the following is or are the adverse effects of hydroxychloroquine? This is purely again the question which is taken up exactly from the concepts which we have explained in SARS-CoV-2 pharmacology. So we have already classified it from top to bottom. We have covered up every individual organ and what all hydroxychloroquine is going to do to every individual organs in the body. But here, as a small recap, again we have clearly given here is multiple answer types. Is it producing retinal damage? Yes, it produces irreversible retinal damage. Aplastic anemia, that is possible. Also, agranulocytosis is also possible with hydroxychloroquine. AV block, this is one of the cardiotoxicity symptoms of hydroxychloroquine. We can also expect what all, guys? Sick sinus syndrome. We can also expect pulmonary hypertension or QT prolongation. All these are cardiac adverse effects, and these cardiac effects and retinal damage warrants discontinuation of therapy. Suicidality, yes, there is a probability of hydroxychloroquine. Clear? It also produces certain other areas like porphyria. We've also explained about life-threatening hypoglycemia. Everything is possible with hydroxychloroquine. Anyhow, here for this question, all the four are the answers for this question, guys. Moving on to the next one. Drugs which acts as a specific TL3 agonistic agent is. TL3 means toll-like receptor 3 agonistic agent. Among this, first option is we have Merimpodib. Merimpodib and Ribavaran, both of these drugs tend to inhibit inosine monophosphate dehydrogenase enzyme, IMPDH enzyme. It tends to inhibit IMPDH enzyme. Ribavaran has got certain other actions, like it might be having an action which is similar to your Remdesivir and Favipiravir, but the effect is going to be least, that mechanism is going to be least useful in treating SARS-CoV-2 infections. Now, tocilizumab and Rintamimod, we'll end up in two different mechanisms. Tocilizumab is a monoclonal antibody which is very much obvious here. Monoclonal antibody against interleukin 6. Interleukin 6 monoclonal antibody. Rintamimod is the drug which is a toll-like receptor 3 agonistic agent. That is the mechanism of this drug, and all these drugs are currently being applied and used for SARS-CoV-2 infections. Now the next question. Find out the false statement. Favipiravir has least activity against DNA viruses. First statement. Favipiravir has got least activity against DNA viruses. Yes, it is a true statement. Why is it? Because we've already seen that Favipiravir is actually a very good virucidal agent, but it is going to act only on the RNA viruses. It has got very least effect on the DNA viruses. Next one, imipenemivir is a broad spectrum virucidal agent. Yes, it is a true statement. Imipenemivir is unlike Favivir, it is not going to act only on the DNA, RNA viruses. Imipenemivir will act at both DNA and RNA viruses, encapsulated, non-encapsulated viruses, any different viruses imipenemivir is going to act on. It is like one of the broad spectrum virucidal agents which we have currently. Remdesivir is also active against Ebola. Yes, Remdesivir is not only active against Ebola, guys, it's also active against Nipah, it is also active against SARS-CoV-2. Right, so many different life-threatening viruses can be cured with Remdesivir. Till now, resistance has been, there is a probability of resistance that RNA-dependent RNA polymerase enzyme might be structurally abnormal. It might be there might be a probability, but it is not seen till now with SARS-CoV-2. It has been seen with other viruses. Till now, SARS-CoV-2 it has not been seen. It might be seen in the future. Hope it doesn't happen. Ribavaran has high in vitro so the statement is a true statement, sorry for that. Ribavaran has high in vitro activity against SARS-CoV-2. No, it's a false statement. Why is it? Because Ribavaran has got a low activity, low in vitro activity against SARS-CoV-2. And that's why it is of least use in treatment of SARS-CoV-2. Clear very. Now the last question. Drug that reduces mortality in SARS-CoV-2 infections patients is steroids, Remdesivir, Favipiravir, low molecular weight heparin. This was the question which was asked last year in your NB National Board of Examinations questions. Steroids is the answer for this question. It is purely taken up from the living guidelines released by the WHO. Here it has been stated clearly that corticosteroids probably reduce mortality and mechanical ventilation in patients with Covid-19. It reduces mortality and chances of mechanical ventilation compared with standard care. Whereas azithromycin, hydroxychloroquine, interferon beta, tocilizumab may not reduce either. Right? It is not going to reduce mortality, it is not going to reduce mechanical ventilation. None of these drugs is going to do that except for corticosteroids. Whether or not Remdesivir confers any patient important benefit remains uncertain. But it has been found like it might reduce mortality, but compared to Remdesivir, we can opt for steroids, and that is the drug which is going to reduce mortality. That's it, guys. Thanks a lot.